Hi everybody, my name is Ashley Hodson and this is my PDSA project for Nursing 451 Nursing Leadership and Professional Issues in relation to catheter-associated urinary tract infections. So issue identification. So the issue or the original problem is reducing and preventing catheter-associated urinary tract infections or CAUTI within the acute care setting. According to the CDC, amongst UTIs acquired in the hospital, approximately 75% are associated with a urinary catheter, which is a tube inserted into the bladder through the urethra to drain urine. Between 15 to 25% of hospital patients receive urinary catheters during their hospital stay. And according to the American Nurses Association, more than 560,000 patients develop CAUTI each year, leading to extended hospital stays, increased healthcare costs, and patient morbidity and mortality. The Institute of Healthcare Improvement provides that urinary tract infections account for approximately 40% of all hospital-acquired infections annually, with fully 80% of hospitals-acquired infections attributable to indwelling urinary catheters. For quality variance, so the standard goal, according to the Office of Disease Prevention and Health Promotion, it targets for the National Acute Care Hospital of CAUTI to be reduced by 25% by 2020 year goal. The CDC also provides a national benchmark for a 5-year prevention target of 25% decrease from baseline for a number of symptomatic UTIs per 1,000 urinary catheter days as measured. And then for my hospital, for Southern California Hospital of Culver City, the goal is to reduce our CAUTI rate to less than 0.92%. So for evidentiary support, from 2009 baseline provided by the Office of Disease Prevention and Health Promotion, there was no change with the 25% reduction goal. CAUTI rates remain at an all-time high, with hospital-acquired infections being a significant cause of illness and death. 1 in 25 patients have an infection related to hospital care. For Southern California Hospital Culver City, we tried to standardize CAUTI rates below, but was not met to adherence and standardization of CAUTI protocol and follow-up teachings. So root cause analysis. So the root problem is that lack of proper hand hygiene prior to Foley catheter insertion or sterile technique insertion and removal. Foley catheters remain inserted longer than necessary. Lack of knowledge for nurse-driven protocols for Foley catheters. Foley catheters are not being regularly cleaned when they're supposed to be. Catheter bags are not being placed correctly due to improper placement at bedside, allowing for retrograde emptying, leading to infection. And many of our stakeholders that are in association is patients, nurses, physicians, physical therapists, quality, and risk management team. So for scope of problem and solution, one of our original problems was the improper hand hygiene during insertion, maintenance, and discontinuation of Foley catheters. So one of our provided solutions, according to the National Institute of Health, reteachings need to be provided of Foley catheters. Prevent catheters from moving by securely being attached to the leg with adhesive tape. The tube remain free of kinks or bends, which prevents urine from draining back to the patient. Catheter is attached differently between genders for men and women. So for men, it's attached to the upper thigh or the lower abdomen. Women, it's attached to the thigh. Every day, the catheter should be washed with soap and water around the perineum area, rinsed and dried properly. Regular cleaning of the drainage bag and sterile technique be maintained when it comes to inserting the Foley catheter. For quality improvement goal, it's to provide reteachings of Foley catheter care at our annual skills fair, hospital-wide to floor staff, and re-evaluation for skills sign-off with return demonstration. Our second problem was Foley catheters remaining inserted longer than necessary. So according to the National Clinical Guidelines of 2012, indwelling catheters should only be used after alternative methods of management have been considered. The patient's clinical need for catheterization should be reviewed regularly and the urinary catheter removed as soon as possible. Catheter insertion, changes, and care should be documented. Follow-up assessment, the best approach to catheterization that takes account of clinical need, anticipated duration of catheterization, and patient preference and risk of infection should be selected. and intermittent catheterization should be used in preference to an indwelling catheter if it is clinically appropriate and a practical option for the patients. So for clinical indications for indwelling catheters, the only time that Foley catheters should be used is for acute urinary retention, chronic urinary retention, if alternative methods have failed, monitoring urinary output of critically ill patients, management of patients with stage 3 to stage 4 pressure ulcers to the perineum, sacrum, or trunk area, an indicated need as a comfort measure for a terminally ill patient if family requested, gross hematuria, and follow-up urological or gynecological surgeries. So for quality improvement goals, we looked to implement an RN to MD communication per 24-hour period protocol for Foley catheter use in our EMR system of all scripts documentation, and continued education for floor staff about clinical indication for an indwelling catheter and when the nurse should request to discontinue it. Our last problem is presence of catheter-associated UTI. So according to Oxford academics, recommended solutions are a closed catheter drainage system where ports in the distal catheter for needle aspiration of urine should be used to reduce CA bacteria A and CAUTI A3 in patients with short-term indwelling urethral or suprapubic catheters and reduce presence of bacteria to patients with long-term indwelling catheters. Institute-specific strategies should be developed to ensure that disconnection of the catheter junction is minimized and the drainage bag and connection tube are always kept below the level of the bladder. Institute should also consider feedback of CA bacteriuria rates to nurses and physicians on a regular basis to reduce the risk of CA bacteria. And hospitals should develop, maintain, and promulgate policies and procedures for recommended catheter insertion indications, insertion and maintenance techniques, and discontinuation strategies and replacement indications. So for quality improvement goals from my CAUTI committee, ours was to implement a new CAUTI Houdini policy that would be released hospital-wide, continued staff education on urinary associated tract infections, and our original goal of reducing CAUTI rate to below 0.92%. So here in left corner is our actual CAUTI policy that we had developed from our committee. So our stakeholders is the infections control department, quality management, patients, physicians, and registered nurses. So by step-by-step goals, step 1 was to develop our new Houdini CAUTI policy with CAUTI committee, RN representatives per floor, which we have a total of 7 floors in our hospital, infection control department, and quality management. Step 2 was finalization and rollout of our new CAUTI policy hospital-wide to all floors. Step 3 was to develop and implement an annual skills fair class, teaching of direct floor staff to the new policy, and skills evaluation checkoff by infection control department, RN staff, and education department. Step 4, adopt of 2 RNs, both day and night shift, to help in the collection, the data collection for CAUTI and monitoring of CAUTI rates, collaborating with the infection control department and RN staff at the bedside to make sure that protocol is being followed. Step 5, of evaluation of CAUTI rate and adherence to the CAUTI policy per unit comparison. And step 6, implementation of new interventions based on a 7th week finding and data collection. So for the projected timeline, it goes from about 1 to 7 months. So within the first month, we've already have developed the new Houdini policy, which I just previously showed on the last slide, and also releasing it. Second month was to do our annual skills fair for the CAUTI and make sure that we had the education classes and pamphlets already set out to be given to clinical staff at the bedside. Month 3, development of the CAUTI task force of adopting the CAUTI CHAMPS as we previously said, which was a 2 RN staff nurse, both night and day shift, for data collection and monitoring for CAUTI rates with infection control department. Month 4 to 6 began data collection measuring per every quarter period of 3 months to catheter insertion, indication, and development of CAUTI present within that time period. And month 7 would be the final reevaluation assessment of CAUTI policy, intervention implemented, and data collection. So analysis of data collection. So for our our collection, we always provide what the clinical indication use of a Foley catheter is, the gate number, date, time, location of the insertion/removal on a time chart, reason for removal and date of removal, name of staff who inserted/removed the Foley catheter, proper maintenance and cleaning documentation, microbial collection for patients who do develop an onset of CAUTI signs and symptoms. Cultures are usually collected and sent as a stat order to our hospital lab. And then whether the patient has an indwelling catheter for long-term or short-term use. So long-term for greater than 30 days and short-term use for less than 30 days. So our next step implementation, if our goals were not met, was to stay up to date with current Houdini CAUTI policy implementations, continue educating our staff at our annual skills fair for proper aseptic technique of insertion and removal of Foley catheters and skills checkoff. Follow up with employee competencies to make supplement additional education when necessary. And if our goal wasn't met, it was to make sure that we reevaluate all of our data collection and our CAUTI policy. That was a completely new policy that was rolled out. And also looking forward to continue to implement new interventions for the policy that was already created. So CAUTI continues to raise costings in the entire healthcare system, millions of dollars, which greatly impacts each hospital annually. And that is my PDSA project. Thank you for tuning in.